Thank you for the opportunity to present the results of our study. Our research is aimed at validating the anastomotic leak risk nomogram by Verzon et al. And the title of our presentation is Risk Nomogram Does Not Predict Anastomotic Leakage After Colon Surgery Accurately, Results of the Multicenter Leg Check Study. None of the authors have disclosures. Anastomotic leakage is a dreaded complication after colorectal surgery, but the prediction of its occurrence is challenging. In 2015, Verzon and colleagues reported 6 risk factors for anastomotic leak based on a study on over 3,000 patients: gender, obesity, anticoagulant use, intraoperative complications, preoperative serum total protein levels, and the hospital size. With these risk factors, they created a nomogram to help the surgeon decide whether to perform an anastomosis or to maybe create a stoma. Although a very good effort, such a nomogram should be validated before it is clinically applicable. Therefore, the aim of this study was to validate the anastomotic leak risk nomogram as proposed by Verzon et al. For our study, we used a prospectively collected international leg check study database containing 1,386 patients who underwent colon resections with the creation of a primary anastomosis. Oral anticoagulant use and serum total protein levels were retrospectively collected as these were not part of the leg check study. Similar to Verzon et al., we excluded all patients who underwent rectum and small bowel resections, and patients whose data were missing for the variables of the nomogram were excluded as well. To compare patients with and without a leak, a univariate analysis was performed. An area under receiver operating characteristic curve analysis was performed for validation of the nomogram. For the preoperative variables, only preoperative hemoglobin was significantly lower in patients with an anastomotic leak. There were no significant differences in age, gender, ASC classification, diagnosis or HSCC stage between patients with or without an anastomotic leak. Intraoperative hypothermia, blood loss of more than 100 ml, intraoperative complication and fecal contamination occurred more often in the leak group. Patients with an anastomotic leak also received epidural analgesia more often, underwent more open procedures, were more often converted to laparotomy, and had a longer duration of surgery. In total, 643 patients met the inclusion criteria, of whom 59 had an anastomotic leakage. The nomogram had an area under the curve of 0.572, meaning we could not validate the nomogram. When the nomogram was tested in patients with a malignancy only, of these 518 patients, 42 patients had an anastomotic leak, and an area under the curve of 0.563 was found. In conclusion, the anastomotic leak risk nomogram as proposed by Verzon et al. Could not be validated using the large prospectively collected leg check study database. In the future, studies on anastomotic leak prediction should also incorporate intraoperative variables, as these are currently missing in anastomotic leak risk nomograms. I would like to thank all participating hospitals of the leg check study and thank you for your attention.